So very welcome today to this webinar on new MRI measures to help monitor and follow up multiple sclerosis patients. Very short overview of what the webinar will be about. So Professor Parizel is here with us today. We'll introduce some MRI measures for multiple sclerosis patients from a radiological perspective. I will follow with a very short introduction, as I mentioned, about icometrix and our measurements. And then we have two neurologists with us, Dr. Lysandropoulos and Professor Nagels, who actually have experience in using the MSmetrix reports in their clinical routine practice. And so they will present some cases and explain to you how they actually use these measurements in their daily clinical routine. So without further ado, I'd like to start this webinar and like to introduce to you Professor Paul Parizel. We're very honored that Professor Parizel is here with us today. Professor Parizel is the chair of the Department of Radiology at the Antwerp University Hospital, and he's a professor at the Antwerp University. He's a former president of the European Society of Neuroradiology, and he's a current president of the European Society of Radiology. So Paul, thank you very much for being here.
Thank you very much, Wim. Likewise, it's a pleasure. I would like to start by showing some information about MR imaging in multiple sclerosis. As you mentioned, I'm a neuroradiologist by training. I'm the chair of the Department of Radiology at the University of Antwerp, and I'm currently serving as the president of the European Society of Radiology. So this is the outline of what I would like to share with you during the next 10 or 12 minutes. We're going to have a short introduction. We are going to look at current standards of practice. Then we will look at the future role of MRI for the diagnosis and follow-up of patients with multiple sclerosis, and have a very brief conclusion. So let's start with the introduction. I'm sure that everybody who's online is familiar with the diagnostic criteria for multiple sclerosis. Since more than 20 years, we are familiar with the Poser criteria, which were criteria that were purely clinical, and there was no imaging. And for the record, Charles Poser was born in Antwerp, in Belgium. He moved with his family to the United States just before the Second World War. I had the pleasure of meeting him several times, and he is one of the true giants in multiple sclerosis because he had was one of the first people to actually understand that you needed criteria to make a diagnosis of definite or probable or possible multiple sclerosis. The Poser criteria were modified in 2001 by Ian MacDonald, another giant in the world of neurology. And he had a classification which was based on clinical criteria, but already assigned a modest role for imaging, and this is Ian MacDonald that many of you will be familiar with. A revision of these criteria was published in 2011. It was actually published in 2010, but the paper was in 2011. This new modified MacDonald criteria included clinical and a more important role for imaging. Now, there is definitely an increasing role of MRI in the diagnosis and monitoring of multiple sclerosis patients. If we look at a time chart, which is starting back in the 1980s somewhere, we see that there's an almost exponential growth in the use of MR imaging for the diagnosis and monitoring of multiple sclerosis. And you see some of the time points on that graph, starting with the Poser criteria, then the MacDonald criteria, and the modified MacDonald criteria. Now, let's look at what are the current standards of MRI practice around the world. I think like most of all of you who are watching us, when we do multiple sclerosis imaging, we would include T1 weighted images. We know that lesions can be either iso-intense or hypo-intense. If they are hypo-intense, they are referred to as black holes, which actually identifies an area of tissue loss of axonal degeneration, and these are irreversible chronic lesions. Most of us are doing T2 weighted images, which show the lesions as hyperintense As you can see in this example in the periventricular white matter, you also may notice that this patient has a significant amount of atrophy. We'll come to that. And then FLAIR, which is a sequence that has been around for 15 or 20 years. Lesions can be either hyperintense, isointense, or hypointense, depending on the stage of the lesion. Most lesions, in fact, are hyperintense, and it is nice that the signal intensity of the CSF is suppressed so that you can nicely identify these lesions at the junction between a CSF-containing space and the white matter. Just to give you an idea of how that works, this is a patient with multiple sclerosis. This is a magnified view of the centrum semiovale and the lateral ventricles. And I would urge you to look at that image and to try to identify the periventricular white matter lesions. Now that's very difficult because the lesions are bright and the CSF is bright. But when you do the FLAIR image in the exact same location, you will see that the lesions are actually outlined because they are bright, whereas the CSF signal is suppressed. So that's a great advantage of FLAIR. Now, gadolinium enhancement in multiple sclerosis, for decades, we have known that when there is a breakdown of the blood-brain barrier, it means that lesions will enhance. It is believed that this enhancement may precede hyperintense lesions on T2-weighted images, and that the enhancement might also precede the clinical symptoms. The window of enhancement in acute plaques is about 2 to 8 weeks, and it is possible that enhancement may persist up to 6 months, but that is not sure. Now, while enhancement is sort of an indicator for disease activity, it is not an absolute indicator because there's a decreasing enhancement during the evolution to secondary progressive stage, and there is very little enhancement in primary progressive multiple sclerosis. Here you can see some examples. If you believe the theory, this enhancement in an acute lesion would be initially nodular. Later, in a reactivated plaque, the enhancement could be ring or arc-like. There might be enhancement of the cranial nerves and enhancement within the spinal cord. And this would be a typical multiple sclerosis patient. You see from left to right, FLAIR, diffusion, T1 without and T1 with GAT. And the yellow arrows are pointing to an enhancing lesion in the left parietal white matter. There's also a small punctate enhancing lesion in the right occipital area, and these are active plaques. Now, if you focus your attention for a moment to the left frontal region, you will see that there is a lesion, a fairly big lesion that is actually not enhancing, and that means there is no breakdown of the blood barrier. You can see that there's actually some tissue loss, so this is a chronic plaque, a chronic lesion that is not active. Now, radiological assessment for most of us currently is mainly visual, so as the Americans would call it, we would do an eyeball assessment. Radiologists experience great difficulty to interpret follow-up scans because of differences in patient positioning, difficulties to assess subtle changes in the lesion load and to count new and old lesions, and the impossibility basically for radiologists to evaluate small changes in brain volume. This is an example where we follow a patient or a subject over multiple years, and when we look at the brain in a multiple sclerosis patient, we know that there is a loss of volume of about 0.6% per year, which is impossible for a radiologist to eyeball. If we look at a normal individual, we know that this loss of volume is about 0.3% per year in a patient who is middle-aged or older. And again, it is not possible to, with the human eye, to see these small differences. Which brings me to the future role of MR for diagnosis and follow-up in patients with multiple sclerosis. Most of you are familiar with the fact that MS is now considered either a neurodegenerative or an inflammatory disease. When we talk about inflammation, we talk about the lesion load, and we look at plaques, which are indicated on this graph in red. When we look at the neurodegenerative aspect, We look basically at brain atrophy, and you can see that the gray matter, the cortical gray matter, is outlined in blue on this image. These two elements will be important in follow-up. There have been a number of MRI guidelines published for multiple sclerosis in different countries, the United States, Canada, France, different organizations such as MSmetrix. I don't have time to go into all of that. I'm sure that you are familiar with most of these things. In current practice, it is recommended that the MRI guidelines for data acquisition in patients with MS should include a minimum field strength of 1.5 Tesla, a single standardized imaging protocol, the time of which should not exceed 25 or 30 minutes of scan time. Follow-up MRI scans should be performed ideally on the same scanner with the same sequence. We use 3D FLAIR sequences, we use 3D T1 sequences, and then you can read at the bottom of the slide the other sequences that are included in the protocol. But the main thing is to have 3D T1, 3D FLAIR, potentially also 3D T2 sequences. Diffusion-weighted imaging could be useful. And again, gadolinium is an essential point of all protocols. Now, for the radiologists, when they are reporting patients with MS, their report should include a number of details, and sufficient details such as the number of gadolinium-enhancing T1 lesions, which is an indicator of activity, the number of new hyperintense T2 FLAIR lesions compared to the previous study, the assessment of the T2 FLAIR lesion burden severity, an assessment of the T2 FLAIR lesion burden compared to the previous study, and ideally also an assessment of brain atrophy compared to the previous study. And here is such an example of where we want to go. We want to acquire 3D sequences, as you can see on the right side of the image, where you can reconstruct the images in axial, sagittal, and coronal planes. You can actually walk through the images, as you see in the animated video on the left, where the lesions have been highlighted in green, and you can actually outline all of the lesions using software to do that. This is not yet a reality, but I think that my fellow speakers will actually focus more on that. So what is the conclusion of this short introduction to imaging patients with multiple sclerosis? Well, first, let me remind you that MRI plays an increasingly important role both in the diagnosis and the follow-up of patients with multiple sclerosis. Standardization of MRI protocols is of paramount importance, and if there's one thing that you will remember, it is to talk with your colleagues to actually standardize your imaging protocols. A protocol should include T1 weighted images, FLAIR, T2, and post-gadolinium T1, and ideally, you should include 3D sequences, which are shown to be superior to 2D sequences for FLAIR and T1 weighted imaging, and which open the gate to volumetric assessment of both lesions and gray matter. And with this, I would like to thank you for being online today. It was a pleasure to talk to you, and I will hand over the microphone again to the moderator of this evening.
Well, thank you very much, Professor Parizel, for this excellent overview of the use of MRI for patients with multiple sclerosis. I will be the next speaker. I see some recommended reading here still from your presentation, which is definitely worthwhile having a look at, and also at the different guidelines that have been published by different organizations on the use of MRI in multiple sclerosis. So I am the co-founder of icometrix. I'm an engineer by background, and during my short presentation, I will just give you a very brief introduction about icometrix and about our efforts to actually make MRI measurements be available for individual patients with multiple sclerosis. A lot more information can be found on our website, so this is just a brief introduction, and if you have any questions, please submit them. So very briefly about icometrix, which is a spin-off company of two Belgian universities and university hospitals of the Antwerp University Hospital, Antwerp University, and the Leuven University. It was established in 2011, 5 years ago, and the mission of icometrix from the start was to bring reliable MRI biomarkers or measures to individual patients. and to really translate all the work that has been done in research to some meaningful measures that can be used in clinical routine practice. And finally, we developed, and along the way, what we call MSmetrix, which are basically our MRI measurements specifically for patients with multiple sclerosis, which contain lesion load and brain atrophy for these individual patients, and which I will give some details about. Now, if you look at multiple sclerosis, and my neurologist colleagues here today with us will know that a lot better than I do. But multiple sclerosis is extremely complex, and there are a lot of treatments available for MS patients. However, if you want to go to a more personalized medicine of multiple sclerosis patients, the treatment should go hand in hand with biomarkers or monitoring tools. And only then we can try to go for a paradigm which says giving the right treatment to the right patient at the right time, which should be the goal. Now, as was very nicely introduced by Professor Parizel, the role of MRI in MS has been really increasing over the past years, and MRI now is a standard for diagnosis as well as for regular monitoring of patients with multiple sclerosis. Here again, you see a 3D FLAIR image, which nicely shows the lesion load of this patient. However, as also mentioned by Professor Parizel, the radiological report is mainly descriptive. It describes the eyeballing of the radiologist about the lesion volume, the changes in time, and maybe about brain volume loss or atrophy. But this is not very objective, and it isn't also quantitative. So that's why we developed software to actually really measure things from the brain MRI. And for that, we start from a FLAIR image and a T1 image, which are used in our analysis pipeline. So the T1 is ideal to make a difference between white and gray matter in CSF to look at the brain tissues. And the FLAIR can be used to then look at the lesions which show bright within the white matter. So after they go into the computers and the software calculates, we end up actually with segmentations, what we call, for example, the brain tissues, white matter, the gray matter in the CSF, and also of the lesions based on the FLAIR image. Now, it's maybe important to just very quickly show what kind of sequences we would need to do such an analysis. And as mentioned, we need a FLAIR and T1 sequence, and preferably they are both 3D sequences, as was highlighted by Professor Parizel in the first presentation. And they're increasingly used. For the FLAIR, we can accept 2D sequences with a maximal slice thickness of 3 millimeters. But that's all what we would need to do a reliable analysis. We don't need very specific parameter settings on the scanner. And these scans can be reliably acquired on a 1.5 or a 3 Tesla MRI scanner. So they can also be scans that don't need to be long research sequences of 8 or 10 minutes. And typically on most scanners, these sequences are required in around 4 to 5 minutes. Now, icometrix is set up as a software as a service, so it resembles a little bit a blood laboratory where some blood samples are obtained, they're sent to a centralized lab, and you receive back a standardized report with the measurements of the blood sample. And this is a bit similar for our brain MRI measurements. All the MRIs nowadays are digital, so they can be sent from anywhere in the world over the internet. So they're centrally analyzed, and then we provide you with a standardized report which gives you information about your brain MRI scan. So about the sending of data, which is quite easy, there's actually 2 ways you can send MRI data to us. The first way is to go to our website and click on upload data, or you can go directly to this website, which is msmetrix.icometrix.com. After you register there as a new user, or you already have an account, you will go to the screen on the bottom right to upload data. You can basically drag and drop the MRI as a zip file into that screen. It uploads for a few minutes, and then our computers will start analyzing the scan. The second option, mainly for centers that would send us more regular MRI scans, is to really integrate in your hospital system. And this means that actually you can send data directly from the PACS to a DICOM router, which we install locally in your hospital. Automatically, the data are sent to our servers, they're analyzed, and the reports and the segmentations are sent back as a DICOM back in the PACS. So that makes it possible actually to just from your hospital environment in the PACS system You just press send the data to icometrix, and then basically 24 hours later, you will receive the report of all the segmentations back in the PACS at the patient in the PACS system. So it's really easy to send the data as well as to look at all the results within your workflow. If you would be interested in that, you can please contact the email address that is mentioned there, integration support@icometrix.com. Now, if you have a look at the report that we send back, this is, we try to keep it as simple as possible, actually. I just highlight a few things. At the top, in addition to some patient information, we send the quality control remarks. So every data set that is submitted to our servers is checked for quality when they come in. So one of our experts will review the data, check if there's some artifacts present or other things. And even after the analysis, when the segmentations are performed, there's a new quality check on the accuracy of the segmentations. If there are any remarks, like a field of view that is too small, or maybe there's other concurrent pathologies present in the patients with multiple sclerosis, that is mentioned there. Then we have some visual results showing in green, actually, the gray matter segmentation, and in red, the lesion segmentation. So it's also possible to download as a DICOM these segmentation overlays, and if you work with the PACS integration, they will be sent back to you, so you can scroll through the images yourself to have an idea how the segmentation is doing. And then we come to the blood lab results, the quantification of the MRI that we provide. First of all, we give you a whole brain and a gray matter volume, as well as a whole brain and gray matter volume loss if we have a previous MRI scan. It's also compared to a healthy population, and you see that in these healthy population graphs, where over the age on the x-axis we show the first and the 99th percentile of how the whole brain volume and the gray matter of healthy population also go down with age. So these are recently updated and are now based on around 1,500 healthy subjects. And then the cross there actually shows you where your patient specifically is compared to the healthy population. So in this case, if you can see it okay, you see two crosses, a white and a black one. The white one is of previous MRI and the black one is of the last MRI. So not only you see how the patient is compared to the healthy population, but also how the patient is progressing. And finally, we have some information based on the flare and the lesion loads. So we provide you with a volume of a lesion volume, and then also change over time if we have a previous MRI scan. And we also indicate what the volume is of the new and the enlarging lesions. So this is basically, if you would submit and send us, upload an MRI, this is the report you will receive back for your individual patients with multiple sclerosis. And these are also the reports that the neurologist here today with us will show you of their patients. Now, just very briefly, some facts and figures about the measures themselves and about icometrix, because I can't go into detail about everything. So we have built a software, so it has an extremely low measurement error, and that is extremely important if you go to one individual patient. So the error of the measurement is around 0.1% now for the whole brain and 0.2% for the gray matter. We also see that our lesion segmentations, which are fully automatic, as all the measurements that we perform correlate very well with expert segmentations that are trained and have to segment lesions for 3 to 4 hours per data set. Icometrix itself is also ISO certified for medical devices as well as for data security. So the MSmetrix software is CE approved for clinical use in Europe, Canada, Australia, and a lot of other countries. And as mentioned, the measurements that we do can be based on just clinical 3D sequences. So it's possible to integrate that with a clinical protocol of 20-25 minutes in every center. Finally, on the clinical use, we obtained our CE approval last year in April. Since then, it has been used in around 40 countries, in more than 150 centers, and we have analyzed more than 4,500 MRI data sets. So it's really great to see that worldwide neurologists and radiologists are interested in receiving the MRI measurements to better follow up their MS patients. And finally, I just wanted to state that the measurements that we perform are really only one part of the complex puzzle that multiple sclerosis is. And And so our measures should be taken into account together with all the clinical information about progression, about with the radiological report, about relapses, about cognition and things like that. And I think that is what my colleague neurologists will show in their case studies. So finally, if you want more information, in addition to the questions you can ask during this webinar, you can email me directly at wim.vanhecke@icometrix.com. You can visit our website. In our Knowledge Center, you find a lot of information there and a lot of presentations. And next week, actually, we will be at the American Academy of Neurology in Vancouver with a booth number 1409. So if you would be there, please come and visit us if you have any more questions. So thank you very much again for being here with us today at this webinar. I will continue the webinar with introducing Dr. Lysandropoulos. Dr. Lysandropoulos is an MS specialist and neurologist at the Université Libre de Bruxelles. He actually recently published a paper where he uses MSmetrix reports in his clinical practice and compares 1.5 and 3 Tesla scanners. And he will present you some cases and how he experiences the use of the MSmetrix reports in his practice. Thank you.
Thank you, Wim. Thank you, icometrix, for hosting this webinar, and thank you all for being here. Let's go from theory to practice, and let's go for individualized medicine. We're going to share with you some practical examples and show you how these parameters, MRI parameters, can influence our choices, speaking about treatment. The first case concerns a young patient doing well for more than 2 years on glatiramer acetate, and in February 2013 he had a mild relapse with a good remission afterwards, and on the MRI in the same time a new T2 and GAD lesion. The EDSS of the patient was 2 at the time of the relapse, and he recovers completely. So based on the algorithm, based on the relapse rate, the lesion load, and of course the EDSS, we were not obliged to change treatment since the patient was doing well on glatiramer acetate. We performed a volumetry, which is something very easy to do. I can confirm what Wim told us earlier. So it's very easy to send MRIs to icometrix. And as you can see, we saw that there was a very low gray matter volume and low whole brain volume, which was something which influenced us to put the patient on a second-line treatment, on fingolimod. So you can see that when you doubt based on the 3 conventional traditional parameters of evaluation of multiple sclerosis, the 4th one, so the brain volume, can influence your decision to go on and change the treatment. And of course, as you can see, the patient changed the treatment and was put on fingolimod. And since the start of this second-line DMT, the brain volume loss has stabilized. So the second case concerned a patient on interferon beta who had a mild relapse in November 2011 with no new lesions on MRI and an EDSS of 3. The patient recovered completely from this relapse. And of course, we changed treatment because of the fact that the localization, the clinical localization of the relapse was medullary. So we wanted to protect the patient better. That's why we put her on a second-line treatment on fingolimod again. And then you can see that we performed volumetry, and since the start of second-line treatment, the whole brain volume and the gray brain volume remained stable, which is something really important because, again, it's the 4th factor, since we know that there is a very good correlation between clinical progression and volumetry. And so when patient wanted to validate the decision of being on fingolimod, to give her the 4th parameter and to tell her that it was stable, it's something who helped her a lot to go on with her treatment. So again, put her on a second-line treatment with good results on brain volume, help the patient to stay on treatment and to be confident of herself that her disease was under control. And so with that, I'm gonna pass again the pointer to Wim for the third case. Thank you very much.
So thank you very much, Dr. Lysandropoulos. It's again my honor and pleasure to introduce to you Professor Nagels. Professor Nagels is the head of the Department of Neurology at the National MS Center in Melsbrook in Belgium. He's also a consultant neurologist at the University Hospital in Brussels. Dr. Nagels, Professor Nagels, is also a specialist and an expert in cognition in multiple sclerosis. So thank you very much for being here.
Thank you, Wim. It's a pleasure to be here at this first icometrix webinar. I would like to share with you two more cases. And I think you will find that my approach to these numbers provided by icometrix is quite similar to my colleague, Dr. Lysandropoulos. I think it's interesting to have these measures on the dashboard when I follow up my patients, when I try to think about them, and when I try to communicate with them. Of course, these volume measurements are not the only parameters that I will use to make clinical decisions. The clinical signs and symptoms of patients remain extremely important, and that's what's summarized on this slide. So the bottom half of the slide shows a data sheet extracted from the EDMUS database that we use in our center. And the bottom part of this EDMUS slide shows the EDSS. So you can see that this patient has reached an EDSS of about 6. The line above that shows the clinical relapses that the patient has experienced. And you can see that this patient has had quite a few relapses, and that the number of relapses has slowed considerably over the evolution of the disease. Especially in this period where he's treated with a second-line disease-modifying drug. And that's the information that you can see on the top third of the white rectangle showing the clinical EDMUS information. The top left of the slide shows measurements made by icometrix and plotted in orange and blue. And you see the percentual change in total brain volume, that's the orange line, and the percentage relative to the baseline measurement, which is placed at 100%, for the gray matter volume, which is the blue line. And in this patient, you can see that the upper line, the total brain volume, more or less follows the rate of atrophy that we would expect in a control group. The blue line seems to be a bit faster, but on the whole, in this period spanning several years, you see that there is about 2% volume loss in the gray matter structures. This raised the question with us, is there something going on that we might not really capture in the EDSS? For instance, is there cognitive deterioration? And we will come back to that in the next slide. The upper right part of the slide shows the lesion volume. And there we see that the lesion volume is more or less constant. And that is, of course, something that we would hope to be the case in a patient treated with a rather strong anti-inflammatory drug. The total lesion volume is reasonable, around 10 milliliters. This is the icometrix report, and we will focus on the green blue graphs, which are represented on the top of this slide. And here you see the volume measurements plotted against the normal control group that Wim already talked about earlier. And we can see that for total brain volume, this patient is in the green zone. And for gray matter atrophy or gray matter volume, measurements are actually below the region where we would like to keep them. Again, making us think of things, evolutions that we are not picking up with the EDSS, such as cognition. The bottom part of this slide shows a cognitive measure. That's the SDMT. In our center, we use SDMT as an additional follow-up for patients treated with natalizumab, which is why we have quite a lot of these measurements for this patient. And we can see that actually there is no sign of decrease in this test at the moment. Of Of course, the SDMT does not show everything, and also we will have to see how the evolution in this patient continues. Overall, I think that the measurements for brain volumes and lesion volumes sort of tell us that we are doing relatively well with this patient, seen in the context, of course, of the therapeutic options that are available for this type of patient. Second patient, if you look at the bottom half of the slide, looks relatively similar because this patient is also in the range of EDSS-6. Both of these patients are male and about 40 years of age, by the way. This patient has also had quite a few relapses. In the beginning, it was a bit less than the previous patient, and this patient is also treated now with a second-line therapy, which seems to suppress the inflammatory activity, which is good. At the top right part of the slide, we see that the lesion volume indeed is not increasing. So that's what we hope for in this kind of therapy. But we see that this patient has a larger volume of lesions than the previous one. And when we look at the left part of the slide, we see that this patient has a considerably higher rate of atrophy. And this confirms a bit my clinical suspicions in this patient, because the previous patient, my clinical feeling there is that we're doing okay. In this patient, I have the feeling that we're not doing okay, and that this patient is actually not really heading for a good place. When we look at the report and when we focus again on the green graphs, which are plotted at the top of this slide, you can see that whole brain volume is considerably lower compared to the normal control group than the previous patient, and also gray matter volume is considerably lower and decreasing. In this patient, we are not seeing a decrease in SDMT function in recent times, but as you can see, the SDMT values are a lot lower than for the previous patient, indicating a greater damage to the cognitive functioning of this patient. So in this patient, unfortunately, the measures confirm my clinical suspicion that we're not doing that well with the patient. And this also helps me to communicate with this patient because he was interested in seeing these measurements. It helps him understand that things are unfortunately not going very well and that we might not be on the right treatment schedule for him for this moment. Of course, the question then is raised, what should we use to treat people who have extensive neurodegenerative activity for their MS? Hopefully the next few years will bring valuable therapeutic alternatives for this group. And so then we get to the conclusions of this part of the webinar. And I would say that what is needed is that we as clinical neurologists should gain additional clinical experience with quantitative measurements of neurodegeneration to get a better feel of the value of these measures and how we can use them to follow up our patients and to communicate with our patients. We should also make sure that every imaging center provides decent images. And with decent images, I mean clinical images, not 2-hour-long sequences, but reasonably timed image sequences, much like those presented by Professor Parizel earlier in this webinar. I think there's also a need for databasing efforts to try and follow up our patients together in databases and to do statistical evaluations of those data. And then prospective longitudinal studies are, of course, also a point of interest in this domain. So that is what I wanted to share with you. Thank you again for the invitation.